based on the registration of reflected pulsed ultrasound signals that are generated by an echocardiographic sensor. So it's usually ultrasound method. There are two types of echocardiography, transtoracic, then the emergency will put in exactly on the projection of the heart. I'm so sorry, I have to answer to my phone, just a minute. I'm sorry, so continue. There are two types of echocardiography. Transtoracic, when the source will put on the projection of the heart on the skin, on the body of the patient, and esophageal. The source with ultrasound will put in through the esophagus to be more closer to the heart. But there is some contradiction and indication for this method. Transesophageal echocardiography, it's not a routine method of diagnostic cardiovascular diseases. We can use it in some additional cases. Routine method, it's strong transthoracic echocardiography. So, and this method based on the registration reflected pulsed ultrasound signal that are generated by this echocardiographic sensor. Or sound. Please switch off your microphones, guys. So the generated impulse of sound wave is reflected at the interface between two media with different acoustic density. The reflected ultrasound signal is captured by an ultrasound transducer and transmitted to a computer information processing system and reflected on the display screen in the form of the bright points measured into the imaging of the object under study. So, and we have to analyze really this picture after this transmission ultrasound wave to picture signal. About possibilities of echocardiography. First of all, it's quantitative and quantitative assess the functional states of the left ventricular and the right ventricular. The volume of these chambers, their density and the duration of the wall of these chambers. Assess regional left ventricular contractility, included in patients with coronary artery diseases. We can find during echocardiography the elements and the area with hypokinesis and zones of akinesis, like a signs of previously coronary heart disease or exactly acute signs of coronary heart disease, like a myocardial infection. Next possibility, to assess left ventricular myocardial mass and to identify ultrasound signs of symmetric and asymmetric hypertrophy and dilatation of the ventricular center atria. So in fact, we can assess all chambers during ultrasound diagnostics, assess the valves and the structure of the valves, and assess the blood supply and find some abnormal regurgitation or abnormal stenosis blood flow in case of echocardiography. Next possibility, assess the condition of the valves apparatus of the heart. We can find stenosis, any kind of valve, mitral, tricuspid, aortic, pulmonary. We can find regurgitation or insufficiency. We can find such damaging like a prolapse and one cusps of the valve, which can lead in also for formation some valve defects. Also, we can assess the level of the pressure in all chambers and identifying signs of pulmonary hypertension. We discussed with you a lot about final diastolic pressure in the chamber of the left ventricular. So Which way we can measure in this pressure, excluded invasive method like a catheterization of the heart, is because it's invasive, more dangerous. We can do it by the ultrasound method of diagnostics, and we can measure in the pressure in all chambers, and take in mind about dilatation, about increasing level of the final diastolic pressure. We can find the signs of pulmonary hypertension, and we can identify the level of this pressure in the trunk of the pulmonary artery during echocardiography. Next possibility, we can identify morphological changes in the pericardium and the presence of fluid in the pericardial cavity. We discussed with you also, yes, during auscultation that we can determine pleuropericardial noise, and during echocardiography we can determine the reason of development of this noise, the presence of fluid in the pericardial cavity, and damaging in the structure of the pericard. We can identify during echocardiography intracardiac formations, blood clots, tumors, extra heart, some additional elements, maybe some additional valve, yes, maybe some addition and some damaging in the structure of the heart, some formations inside the cavity of the heart. We can evaluate the morphological and functional changes of the main and peripheral arteries and veins, included surrounded main arteries and veins surrounded the heart. So, and if you look to the purpose and the changes which we can determine during echocardiography, you can understand that it's multidisciplinary, and it's one of the most important methods of the diagnostic of the cardiovascular system, one of the important non-invasive method of diagnostic. It's routine, it's really not very hard to put the source of ultrasound, fraction of the heart, and assess all these points. Look to this picture. Yes, it's a picture. First, it's a scheme of echocardiography in M mode on 1D seminal sonography region. And another one, it's really picture of echocardiography. And look, if the source of ultrasound, there is it, yes, it will be a source. In case of transthoracic ultrasound method of diagnostics, first of all, you can determine the tissue or cost elements of anterior chest wall. Yes, we can't exclude it from the picture imaging. So, first of all, next one, it depends from in which place you put the source of this ultrasound method. Next, you can determine the wall of the right ventricular, anterior wall. Next, it's the exactly chamber of the right ventricular, and look, it's just in front projection, yes? After that, it's interventricular septum. Also, we can determine defect in the structure of interventricular septum. Next, it's a big chamber of the left ventricular. Look, left ventricular. You can't determine in this projection, yes, the chamber of the left atrium and the chamber of the right atrium, because the right atrium will come down from the right ventricular. But if you will know anomaly structure, anomaly anatomy of the heart, you can understand where is with projection the main chambers. How we can differentiate it, the right ventricular chamber from the left ventricular chamber? By the size, yes. We discussed with you again and again, but the massive myocardium of the left ventricle more bigger than the massive myocardium of the right ventricle. And you can assess it during echocardiography. Yes, look, yes, the massive myocardium, it means that the volume of the left ventricle is more bigger than the volume of the right ventricle. And look to the real echocardiography from the right side of slide. what it is. It's a chamber of the right ventricle. Yes, it's a chamber of the left ventricle. It's a chamber of the left atrium. Look how we can understand where is left ventricle, where is left atrium. Yes, because it's really not very simple to understand. We can look to direct of the cusps of the mitral valve, yes, or B-cusps valve, and look the direct of opening in normal to direction of the left ventricle. And if you look to this picture, yes, look there, the direction of the cusps will be exactly to the inside of the chamber of the left ventricle. This way we can determine and differentiate the chamber of atriums from the chambers of ventricles. So look, some another pictures with echocardiograms. Chamber of the left ventricle, the most bigger, yes. Left atrium, right atrium, right ventricular. Also, direction of opening of cusps of the valves in tricuspid valve. Some another projection. This projection depends from the place where you will put the source of ultrasound. Left ventricular, left atrium, right ventricular. We can't assess their right atrium. Also, you have to know that there is some special region or some additional region, and we can call the Doppler mode to Doppler region. During this region, we can assess the blood supply and the blood flow of inside the heart and circulation, the blood flow inside the heart. So we can assess in which chamber, which type of blood will be present in which phase of the cycle. For differentiated valve damaging, for differentiated damaging of the interventricular septum. And look, surely the red color or the orange color, like this picture, it will be arterial blood. And the blue color, it will be the nodules type of blood. Yes, and you can understand which type of blood will be present in which chamber and during changing the phases of the cardiac cycle. So it's the base about heart echocardiography. Next, about bicycle ergometry or daily ergometry, bicycle ergometry. I think you discussed it in the functional diagnostic also. And this method, it's carried out using a bicycle ergometer that allows you to strictly dose and to dosage the physical activity and in increasing the load of physical activity and evaluate the amount of work performed in watts. Yes, in watts, and the doctor can increase in under the control the level of this load. And an ECG is sphygmomanometer for measuring blood pressure, and phenendoscope are also required for the test for assessing all parameters of the cardiovascular system. And the load is increased stepwise every 3 minutes, starting with a power from the 25 or 50 watts, and an increasing load of 25 watts is usually carried out continuously and stepwise for 15 and 18 minutes. And look at this picture, yes, under the doctor control, increasing the load for the patient to assess, first of all, answer from the blood pressure and to detecting the maximum level of the blood pressure, which can be a signal to stop in this test. And also during this activity, we will determining ECG of the patient. Sure, first of all, for which pathology we need to check this test. For coronary heart disease, yes, for finding some hidden types of conclusion of the coronary arteries. Look, electrodes, yes, for determining ECG and measuring the blood pressure simultaneously. Next type of test for cardiovascular system is treadmill tests. Practically they're similar, but other objectives of bicycle ergometry and treadmill tests: identification of clinical and electrocardiographic signs of myocardial ischemia, so the diagnosis of coronary heart disease, the main indications for treadmill tests and for the ergometry or bicycle ergometry. What I mean when I told you about clinical signs, sure, it's pain in the heart region is under the sternum with classical localization and the radiation like a clinical sign of coronary heart disease. Sometimes during hiding obstruction, we will determine with you only a T-segment elevation like an electrocardiographic sign of coronary heart disease, the main. And also during this method of diagnostics, we can assess and we can determination the tolerance to physical activity from the side of the patient. It's a picture, a patient with treadmill tests, and you can assess, yes, the level. There's some dates about the patient on the first monitor and the loading, the level of the loading for the patient, and exactly registration of ECG during all time of this method, during a longer time. And after that, you can print this ECG and take a time for analyze. But this method give you some additional information, yes, and will show you where will be some abnormal elements on the ECG. Next type of ECG monitoring, it's a Holter ECG monitoring. This along, often a daily, at real time by the last recommendation, more better doing during 48 hours, not for 24, if it's possible, during 2 days, during 48 hours. Registration of an ECG from the 2 till the 12 standard leads. It depends from the type of the monitoring, from the type of monitor. And this registration, which is carried out autonomously and in the hospital or in outpatient basis or at home, in conditions as close as possible to everyday life of the subject, of the patient, to registrate it really level of the abnormalities on the ECG. The device consists of a lead system, a special device which records an ECG on a magnetic tape, and a stationary pacemaker. A miniature recording device and electrodes are mounted on the patient's body, and during the study the patient keeps a diary, and you have to tell to the patient that the patient need to write a diary with all types of activity during this 48 or 22 hours during this diagnostics, for checking you which type of loading which leads to elevation or depression segment ST, and for developing such type of arrhythmias like a sign of coronary heart disease also. So keep a diary in which data are entered on the nature of the patient load and subjective discomfort. Also, there is a special point, and on this point, the patient can press during uncomfortable feelings, and it will be marked for you with some disturbing for patient, and you can consider it this moment of disturbing for patient with the date on the ECG. So such indication for Holter ECG you have to know: detection of ischemia, shivering, different types of arrhythmias, and mark of treatment. Sometimes you can do ECG, Holter ECG monitoring for the recurrence patient to assess the effects from your treatment and to consider it the nature of your treatment. It's just usually a way of putting Holter monitoring. Look for electrodes, yes, excluded some, yes, and not so standard points for electrodes. It depends from the type of these devices. In small devices, you should round it closer to this electrodes for bad net, for good net between it, and to put into and to round it, or for the special devices by the abdominal of the patient. Next, also very important method for the diagnostic cardiovascular diseases, daily monitoring of blood pressure, or BP monitoring, or daily monitoring of blood pressure. It's the same methods. Daily monitoring blood pressure is a diagnostic technique which based on long-term daily, what it is daily 24 hours monitoring of blood pressure and heart rate. Monitor blood pressure measurement is carried out also automatically according to a given program every 15 minutes during the day times and 30 minutes during the night time. It's not so comfortable procedure for patient, but we have to do it. You can also change the program and exclude the voice before each measurement the blood pressure. Because in classical program, before the starting measurement of the blood pressure, the patient will hear some voice signal from the monitor from devices. It's not very comfortable during the night day, and if you can exclude this voice for better sleeping and for give a patient more comfortable condition, for better results, for real results, and assess these results. So classically 50 minutes in daily time and 30 minutes in night time, measuring the blood every 15 minutes, every 30 minutes. The cuff from these devices is one of the shoulder of our patient and connect to a wearable device, power supply, compressor, automatic blood pressure measurement unit. It's a complex, yes, for these devices for daily monitoring blood pressure. About some plus advantages of the method about BP monitoring. Provides information about blood pressure during everyday activity and at night, and we can assess with you normally and abnormally maybe levels of the blood pressure during routine activity of the patient, during the sport, during the taking some home activity, during the sleep, and during the taking the meal, during all activities. And also you can ask a patient to make a special diary with activities, and the same with the Holter ECG monitoring, putting some uncomfortable marks. Also, BP monitoring allows you to determine the daily rhythm of the blood pressure, night hypotension and night hypertension, the dynamics of blood pressure in time, and the uniformity of the antihypertensive effects of the drugs and results after your treatment. And during the interpretation of daily monitoring BP, the main attention should be paid to the average blood pressure values for day, night and day, and their ratios. Allows you to identify hypertension white code. Also, you will use it to exclude the hypertension of white coat. It's a special type of hypertension from the arterial hypertension when the patient will have a high level of the blood pressure only during the contact with the doctor. It's a photo of devices for BP monitoring. These devices form the main block, yes, with the main computer system. This tube for contact with the scarf for measuring blood pressure, and it's a tube. So also on the block, you can identify a special point for blockage the measuring of the blood pressure during some uncomfortable condition of the patient. For example, the patient will be in the toilet. Yes, it's not normally uncomfortable for patient, and the patient can block this measuring, and this measuring will be losing and missed from the analysis. Next type of method is radionuclide research method. More often, scintigraphy of the myocard or scintigraphy of the heart muscle is used. This is a method for myocardial imaging based on the ability of an intact or necrotic myocardium to accumulate some radioactive components and composing. So yes, after using these components, also we can identify some damaging wall and some damaging myocardium of the heart. Myocardial scintigraphy with thallium-201 is used to detect local coronary blood flow disorders in patients with coronary artery disease. With normal coronary blood flow, about 85 and 90% of it, the nosus thallium is captured by the myocardium. And if the coronary blood flow will be disturbed, the level of extraction of the substance in the pool of northern coronary artery decreases. Myocardial scintigraphy with another substance, with technetium-99, pyrophosphate, is used to visualize areas of the heart attack because the substance selectivity accumulators in the necrotic tissue of the heart muscle is at least 30 and 40 of the blood flow remains in the affected area. So a result depends from the type of substance, technetium-99 or thallium-201, and collecting and composing the substance depends from the structure of the healthy or unhealthy myocard. So, about method of diagnostics of the cardiovascular system, let's return in. The most simple, yes, the most routine X-ray method of diagnostics of the cardiovascular system with assessing the configuration of the heart, with assessing the signs of pulmonary hypertension, with assessing the signs of stagnation of the blood and the small cycle of circulation. CT scan more detectable for damaging of the coronary artery, and exactly we have to identify the calcinosis of the coronary artery like a sign of atherosclerosis, atherosclerotic damaging. The gold standard in the invasive method of diagnostics of cardiovascular disease and exactly condition and the initial inside part, the initial part of the coronary artery, it's a coronary angiography with indications and contraindication. Yes, different type of sourcing, radial and femoral sourcing or access. What we have to determine the spasm or occlusion of the coronary artery. We can identify different type of blood supplying. Yes, middle type, right and left type of blood supplying. magnetic resonance imaging for detecting changes. We can identify also using the contrast components for conclusion of the coronary artery, but more informative MRI for determining the damaging of the myocardial cells. Heart echocardiography, most important from the non-invasive method to ultrasound method of diagnostics. We can identify volume of the all chambers, structure of the valves, cusps, valve apparatus, assess the level of the pressure inside all chambers, assess the level of the pressure in the pulmonary artery, assess the structure of the main arteries and veins surrounding the heart. Two types of echocardiography, transtorsals and transesophageal. Additional Doppler mode, it's not additional, yes, it's also routine, but there are M region without assessing the blood supply and the circulation of the blood, and additional Doppler mode for assessing the blood supply and blood flow inside the heart. Test with the load, bicycle ergometry, and treadmill tests for determining clinical signs and electro ECG signs of coronary heart disease like elevation and depression ST segment. Daily monitoring ECG or Holter monitoring ECG for determining ischemia. Daily monitoring of blood pressure if we considering the duration of Holter monitoring, we have to do it during more better during 8 hours. And about daily monitoring blood pressure, by the last recommendation, only 24 hours for routine activities of the patient to determining the level of the blood pressure and to assess the effects after treatment. And the last one type, a radionuclide method of researching and determining cardiovascular disease, included scintigraphy with the Telium-201 and scintigraphy with the technetium-99. So I suggest you to remind us some the main clinical symptoms of the disease, the cardiovascular system. From the next lecture, we'll start about digestive system. Which types of syndrome we can differentiate it in the pathology of the cardiovascular system. Circulatory failure, heart failure, acute and chronic failure, vascular insufficiency, acute and chronic insufficiency, syndromes of disorders of the valves of the heart, mitral valve insufficiency, mitral stenosis, aortic stenosis, aortic regurgitation or aortic insufficiency, tricuspid valve insufficiency or tricuspid regurgitation, tricuspid stenosis, stenosis of the pulmonary artery, insufficiency of the pulmonary artery, aortic stenosis and aortic insufficiency. Combined and heart defects, syndrome of acute and chronic coronary insufficiency, hypertension syndrome, fluid syndrome in the pericardial region, and the presence of the fluid we can assess during routine ECG, constrictive pericardial syndrome, and syndrome of pulmonary hypertension and pulmonary heart. About circulatory failure syndrome, chronic circulatory failure. Classification of the heart failure by the New York Heart Association differentiated 4 classes of the heart failure. First class, there is a heart disease, but it does not limit the physical activity of our patient, and normal exercise does not cause severe fatigue, palpitation, or shortness of breath in patient. Second class of heart failure. Heart disease leads to a slight restriction, to a slight limitation of the physical activity of patient. At rest, there are no symptoms, no clinical symptoms like a shortness of breath, like a palpitation. Planned physical activity causes fatigue, palpitation, and shortness of breath. Third class, heart disease leads to a significant limitation of physical activity. At rest, there are no symptoms, but less common activity can lead into development general fatigue, palpitation, and shortness of breath. And the last class or fourth class of heart failure, heart disease leads to severe restriction in physical activity and heart symptoms, insufficiency, and engine appears at rest. With any activities, the symptoms intensify. Classification of heart failure or chronic circulatory failure by the Strajewski and Vasilenko. Stage 1, also we can differentiate it 3 stages, but second stage we can divide it into 2 blocks, A and B. Stage 1, it's initial or hidden heart failure. Shortness of breath, tachycardia, mild cyanosis during exercising, like a sign of echocardiogram during the heart failure. Hemodynamics and organ function at rest are not impaired, and normal working capacity is slightly reduced. Second stage, severe stage of heart failure. Blood stasis in the small and or large cycle of blood circulation with impaired function of organs at rest. Disability reduced in this stage, second periods, and we can differentiate it two substages. 2A, characterized by minor hemodynamic abnormalities, for example, only stagnation of the blood in the lungs, or in the big cycle or large cycle of circulation. And to be stages manifested by deep hemodynamic disturbance and total damaging of the circulatory systems, and stagnation of the blood by the 2 cycle of circulation, small and large cycle of circulation. Third stage of final dystrophic with a contrast hemodynamic disorders and deep irreversible metabolic disorders in the structure of the heart. Which cause can lead to development heart failure in patient? Myocardial overstains caused by working overload, pressure, volume, a violation of the blood supply to the myocardium, myocardial damaging, acute and chronic, metabolic disorders, nutritional deficiency, electrolyte substance, pathological hormonal alcohol intoxication, drugs intoxication, medicine intoxication. The presence of fluid in the pericardial cavity for pressing mechanism of the contractility of the chambers, pericardial fusion, development of the cardiac tamponade, arrhythmias and heart blocks, and changes in the department of the heart, which provide an environment in its contractile function, consist of the expansion of the cavities of the heart, dilatation, and myocardial hypertrophy. Clinical manifestation of heart failure can manifest from the tachycardia, from the dyspnea, shortness of breath, from the cardiac asthma, from the pulmonary edema, from congestive enlargement of the liver, from edema and cyanosis signs. Acute left ventricular failure. Which reasons? Late stage of the disease, which accompanied by a load on the left ventricular, severe arterial hypertension, hypertensive crises, aortic and mitral heart defects, myocardial infarction, disordered heart rate, cardiosclerosis, and cardiopathy. Against on the background of the chronic left ventricular failure, and it's provoked by physical and emotional stress, dilatation coronary circulation, increased blood pressure, tachycardia, and exposure to infection factors. Acute left ventricular failure often develops at night and manifested by cardiac asthma or pulmonary edema. The main reason of developing acute right ventricular failure, and we discussed it with you, that it's embolism of the large branch of the pulmonary artery. During examination, what we can find? Swelling of the cervical veins, painful enlargement of the liver, and severe cyanosis and tachycardia during general examination. And look to the picture. Yes, at this picture we can identify clinical assessment in acute heart failure during examination. Jugular venous destination, third heart sound for due to mechanism increasing final diastolic pressure in the left ventricular chamber. Pulmonary crepitation due to mechanism of stagnation in the system of the pulmonary circulation. Hemodynamic disturbance due to mechanism damaging in the small cycle of circulation, which leading to reducing cardiac output, yes, and decreasing the level of the systolic BP less than 90 and the diastolic BP less than 60, and peripheral edema, also significant for patients with acute heart failure. Chronic left ventricular failure. The main reasons for disease occurring with a predominant load to the left ventricle and associated with the nasal congestion of the lungs. Complaints of the patient during your speaking with patient, gradual increase in shortness of breath, and the main complaint from the chronic left ventricular failure will be shortness of breath or dyspnea, tendency to tachycardia for some palpitation, dry cough at night during increasing the preload for the right side. Shortness of breath appears first during physical extension, and then at rest. It's amplified in the prone position. During inspection, we can identify patient in position of atopnea. During palpation, the heart region, we can identify that the apical impulse will be moved to the left and down due to dilatation the chamber of the left ventricle, and alternating pulses possible. During percussion, dullness of the sound in the loud parts of the lungs behind. During percussion of the lungs, you will determine dual type of sound on the projection. Normally, pulmonary clear sound, that will be a sign of vascular stagnation in the small cycle of circulation. During auscultation of the lungs, increased vesicular breathing, increased loudly vesicular breathing or hard breathing detection, sometimes inaudible moist final bubble raised from the both sides. With auscultation of the heart, we can identify with you a gallop rhythm, which will be a sign of heart failure, which consists from the attenuation of the first tone and formation additional third tone. Dilatation of the left ventricle is often accompanied by a sign of relative mitral insufficiency and will accompany with systolic murmur of the mitral insufficiency, which we can determine on the apex of the heart and the first point of auscultation for mitral valve, and also leading to attenuation of the first tone. So it's a mechanism of formation, the gallop rhythm, which is significant for patients with heart failure. Left side heart failure. Chronic right failure. The reason of development. Joins the left ventricle due to deep pulmonary circulation disorders, increased pressure in the system pulmonary artery and other load of the right heart. Isolated right ventricular failure occurs against the background of chronic lung disease, pulmonary heart defects leading to other load of the right ventricle, constrictive and exudative pericarditis. About clinical manifestation, chronic right failure, general weakness, heaviness in the right hypochondrium, persistent tachycardia, pastility or swelling of the legs, swelling of the cervical veins and enlarged liver, nocturia, oliguria and some reducing in the filtrate of the urine, and moderate proteinuria and present some proteins in the general urine analysis associated with the nasal congestion in the kidney only. By the physical examination, during physical examination, we can determine signs of right ventricular hypertrophy, cardiac impulse. We will determine during right ventricular hypertrophy, shift of the border of the relative dullness of the heart to the right, and we can identify pathological epigastrical pulsation. With corresponding changes on the ECG are detected, and on ECG you will identify signs of hypertrophy of right ventricular. So, left side heart failure, about clinical signs. confusion, position of orthopnea, yes, tachycardia and palpitation, extensional dyspnea, fatigue, cyanosis, echocardiogram. Look to the picture. Yes, cyanosis of the mouth, of the nasolabial triangle, the distal phalanx on the arms, the distal phalanx on the foot, paroxysmal nocturnal dyspnea and cardiac asthma, elevated pulmonary capillary wedge pressure, and pulmonary congestion. Signs: cough, crackles on the base of the lungs, wheezing, blood-tinged sputum, and tachypnea. Right side failure. Also fatigue, increase in peripheral venous pressure, development ascites and enlargement in the size of abdominal cavity due to collecting the liquid inside, enlarged liver and spleen due to collecting and stagnation of the blood. Also, right side heart failure can be secondary from the chronic pulmonary problem, for example, from the COPD, distance at jugular veins, anorexia and losing the weight of the patient, complaints of gastrointestinal distress syndrome, weight gain, and dependent edema on the feet firstly. Next syndrome, it's a syndrome of acute and coronary insufficiency. There are acute and chronic coronary insufficiency. Acute coronary insufficiency occurs suddenly or within a few minutes. What about reasons? Dilation of the functional state of the coronary arteries, spasm, dystonia, atherosclerotic plaque, coronary artery thrombosis, and acute increased myocardial oxygen demands. Chronic coronary insufficiency develops gradually and has a progressive character. About the reason: prolonged, recurrent, and progressive relation of the coronary arteries, which lead into their persistent northern occlusion. Common causes of coronary insufficiency, acute and chronic. Atherosclerotic on the first place, rheumatism with the damaging of the structure of the coronary arteries, nodular periarteritis, cardiomyopathy, hypertrophic cardiomyopathy, hemodynamic changes of non-coronary genesis with stenosis of the aortic orifice and aortic valve insufficiency, aortic stenosis of the aortic valve insufficiency, leading to decrease the level of blood supply of coronary artery, because coronary artery is also a branch of the aorta. Complaints: pain in the heart, like a main complaint the patient with acute and chronic coronary insufficiency. About the nature of the pain will compressive or oppressive. Localization of the pain under the sternum or in the atrial region along the left edge of the sternum. Classical irradiation of the pain in the left shoulder, left arm, left half of the neck and head, low jaw, interscapular space, and sometimes in the upper abdominal in the epigastrical region. Possible atypical irradiation of the pain to the right side of the body. About relationship between the appearance of the painetics and physical activity, duration of the pain no more than 10 minutes from the moment of termination load, during inspection of the patient will motionless, the skin is pale, sometimes droplets of cold sweat appear on the face, the expression of the face is frozen, some alarmed or frightened, eyes are wide open, fear or death, and we discuss it with you. Some people will tell you about it. At the time of anesthetic of the chest pain, tachycardia and extrasystole are often found during ECG diagnostics and using routine diagnostic. During auscultation, we can identify muffled heart sounds. On ECG, during the painetics, the displacement of ST segment is more than 2 millimeters down or up, elevation or depression of ST segment, but more than 2 millimeters. It's a critical criteria for coronary heart disease. Acute coronary insufficiency. develop suddenly or within a few minutes and can last up to 1.5 and 2 hours. Instability of coronary blood flow occurs as a result of a dynamic or reversible disturbance of coronary circulation. It lasts for 5–10 minutes, after which the disturbed metabolic process in the myocardium are completely restored angina pectoris. In severe acute coronary insufficiency with last for 1.5 till the 2 hours, zones of dystrophy and areas of necrosis forms in the ischemic myocardium, that is a severe form of coronary heart disease, occurs due to myocardial infection. The main clinical signs of the severity of acute coronary insufficiency is the intensity of the pain attack and duration more than 15 minutes. 15 minutes is a critical point for differentiated chronic or acute or exacerbation of chronic coronary disease. Chronic coronary insufficiency is a consequence of chronic, often atherosclerotic lesion of the coronary vessels and formed other many months and years. Clinically, chronic coronary insufficiency expressed by repeated angina attacks during the time of varying severity, shortness of breath like equivalent of the pain attack, cardiac arrhythmias and chronic heart failure, which occur initially during physical and emotional stress and when at rest. During auscultation, also we can identify MAF tones on ECG, persistent ST segment depression with biphasic moved or negative T wave after ST segment. So the last classification of coronary heart disease. In the first place, sudden cardiac death, angina pectoris, which we can differentiate into stable angina pectoris and indicate in the functional classes. Unstable angina pectoris, the first arising angina pectoris, progressive angina pectoris, early post-infection or post-operative angina pectoris, spontaneously or diaspastic adherent or Prince-Metal angina pectoris, painless myocardial ischemia, microvascular angina pectoris, and associated cardiac X syndrome, myocardial infection, which we can differentiate it with Q wave with ST elevation and non-ST elevation without Q wave. Next, post-infarction cardiosclerosis, heart failure. Also, we put into the classification of coronary heart disease, indicating with the former stages by the two classification by the New York Heart Association classification and the Strategic and Desilenko, and violation of the heart rhythm and conduction with indication of the special forms of arrhythmias. So, about classification, the stable angina pectoris. There are 4 functional classes of stable angina pectoris. First functional class is attacks and head attack of ischemic external pain occur only at high level of the load and performed for a long time at a fast pace. Latent coronary insufficiency. Second functional classes of stable angina pectoris. A slight limitation of the usual physical activity. Pain attacks occur at an average pace of walking 80 until 100 steps in 1 minute on a flat place at a distance of over 500 meters, especially in damp cold weather against the wind when climbing stairs above one floor. Third functional classes, a pronounced limitation of the usual physical activity. Attacks occur immediately when accelerating walking, running, or walking at an average pace in a flat pace at a distance from the 100 till 500 meters, and then climbing to the and going to the first floor of the staircase. And last, the fourth functional classes, pronounced limitation physical activity of the patient with minimum domestic and emotional stress leading to development heart attack of patient and patient are not able to perform the slightest physical activity without an attack of pain and the occurrence of pain attacks during the rest. Next, arterial hypertension syndrome. Arterial hypertension is a term with an increase in the level of the blood pressure, and arterial hypertension is an independent nosological unit, like essential or primary hypertension, is a disease with a specific etiology and pathogenesis, in which an increase in blood pressure from the very beginning is the main and leading sign, and it's not caused by the pathology of other organs and systems. And from another side, we can differentiate in symptomatic or secondary hypertension. It's an increased level of the blood pressure is one of the symptoms of some other main disease, like glomerulonephritis, renal artery stenosis, aortic insufficiency. The main complaints patient with arterial hypertension is, first of all, headache, more often in the occipital or parietal areas. It's noted in any time of the day and depends from the level of the pressure. It not depends from the day or night time. But its nature, pulsating or constricting, dizziness, a change in vision, flying flies in front of eyes. Next complaints, the appearance of spot and circles in front of the eyes and decrease the level of the vision on the short time. Stitching and itching pains in the left precordial region, also which contact with the increasing level of the blood pressure, cause increasing load for the heart, and these complaints stop after a decrease in the level of the blood pressure. During objective examination, we can identify patients often have a hyperstenic constitution, it's more significant, increased nutrition, the face can be hyperemic, maybe not, apical impulse will be spiraled due to hypertrophy of left ventriculum, resistance and shifting to the left due to dilatation of the left ventricular, and sometimes down to the 6 intercostal space. Depends from the level of the dilatation. Arterial pulse filling is full and voltage is solid. During percussion of the heart region, we will determine the left border of the relative dullness of the heart is shifting to the left, and in the 5th or 6th intercostal space due to dilatation of the left ventricular, the aortic configuration of the heart will be formed due to dilatation of the left ventricular and amplified weight of the heart. During auscultation, first tone in the apex will be attenuated. The empiphysis or ascent the second tone above the aorta due to increase the level of the blood pressure and increase the speed of returning of the blood. As the aortic configuration of the heart forms in the apex, and functional systolic murmur can be had due to the relative insufficiency of the mitral valve due to stretching the ring of the mitral valve. Due to instrumental method for diagnostics and target organ damage in patients with arterial hypertension syndrome, due to X-ray, the aorta is compacted and can be expanded. Heart aortic configuration due to dilatation in the chamber of the left ventriculum. During ECG, all signs of left ventricular hypertrophy and can be present signs of systolic left ventricular underload. During echocardiogram ultrasound method, signs of left ventricular hypertrophy and dilatation, and we can measure in the level and the density of the wall and the volume of the left ventricular chamber. Violation of the diastolic and systolic function of the left ventricle, and ocular fundus, yes, or signs from the ophthalmologist. Retinal arteries and arterioles narrowing, have a more rectilinear cursus than usual. The veins are dilated, convoluted, and there tartuinousy in the macula of a symptom of Geist, and the wall of the artery is compacted. It presses on the underlying vein and causes it to narrow to the intersection or symptom of an intersection of Hans series first degree. Also, measurement of the blood pressure according by the method of Korotkov using a sphygmomanometer and daily monitoring BP for understanding the reason of developing arterial hypertension. European Society of Hypertension classification, whereas optimal level less than 120 and less than 90, normal less than 130 and less than 85, high normal pressure from the level of the 130 till 139, and diastolic from the 85 till 89. First grade of hypertension level between 140 till 159 diastolic till the 99. Second grade 160 till 179 and diastolic from the 100 till 109. And third grade more than 180 and more than 110 diastolic. Here's level of the pressure. And American Heart Association, some in other levels, normal level the same, less than 120 and less than 80, elevated 120, 129, but diastolic less than 80, high blood pressure 130, 139, and diastolic 889. Stage second one, 140 and more, 90 and more, and hypertensive crises higher than 180 and higher than 120.